travels through the atria, then it comes to AV node, and then into the ventricles. So the reflection of this electrical impulse on the paper, it is called ECG. ECG is the electrical interpretation of the electrical activity of the heart, right? So what is ECG? ECG is the electrical representation of the electrical activity of the heart. So this is called ECG, and it has got a particular type of, a special type of waves over the ECG, the P wave and then QRS complex and T wave. You know that all. This is the normal pattern, and if the P wave is followed by QRS complex and all is normal in its morphology and its rhythm, then it is okay. If anything that disrupts this electrical traveling or electrical activity of the heart from the SNO to the atria and at the AV nodal level, so it causes arrhythmia. So we have two type of arrhythmias: bradyarrhythmias and tachyarrhythmias. So now, first of all, we are going to discuss bradyarrhythmias. Sinus node dysfunction, inappropriate sinus bradycardia, sinoatrial exit block, sinoatrial arrest, tachybrady syndrome. But these arrhythmias are less common. What is common? The common is AV nodal blocks. First degree AV block, second degree AV block type 1, second degree AV block type 2, and third degree AV block. So these AV nodal blocks are more common in clinical practice. So you should know about these AV nodal blocks. What could be the causes of AV blocks? It may be due to some drugs like beta blockers, calcium channel blockers, digoxin. So it may be due to some kind of drugs. So it's called drug-induced bradycardia or drug-induced AV block. Similarly, ischemic heart disease, inferior wall MI is commonly associated with AV nodal blocks. Congenital, like ostium primum, AHD, and transposition of great vessels. These congenital diseases are commonly associated with AV nodal blocks. Similarly, infiltrative disease like amyloidosis, if it is infiltrated into the AV node, it causes AV nodal block. Infections like infective endocarditis, if the infection is extended towards the AV node, it can damage the AV node and cause AV nodal block. Hyperkalemia is very common. It causes a AV nodal block and bradycardia. Similarly, trauma during cardiac surgery, if the surgeon is not very careful, he or she can damage the AV node and causes iatrogenic AV block. So what may be the features, symptoms like presyncope, syncope, fatigue, and you can have Cannon waves over the JVP and variable rate and amplitude of arterial pulse. If you feel the pulse, it may be irregular. The rate is variable S1, soft to progressively soft and constantly changing depending upon which kind of block you have. So if the first degree AV block, it may be soft, and then if it's Venki back, then it's progressively soft, and if it is third degree AV block, then it's constantly changing. So if you are very careful in examining the patient, and if you auscultate and you are able to appreciating S1, so you can have some idea about the block, which kind of block it is, without seeing the ECG. So this is about the clinical features. But if you have ECG, so first of all, you should know about the ECG paper. Do you have any previous class about the normal ECG or something else? Yes, moderator. पहले कोई क्लास हुई है आपकी ECG पे? Can you hear me? Moderator, can you hear me please? आप मुझे सुन सकते हैं? आप मुझे सुन रहे हैं? Okay. So if you see the ECG paper, you will have some boxes like small boxes and the large boxes. The small boxes is equal to 40 millisecond or zero point zero 0.04 seconds. And in large box, you will have one, two, three, four, five small boxes. And altogether, it is equal to zero point 0.2 seconds or 200 milliseconds. So this is about the ECG paper. And if you see there's rhythm, okay? So you should have P wave and then QRS complex and then T wave. So you should know about the normal morphology of the P wave and QRS complex and T wave. So this is P wave, right? And then this is PR interval. And PR interval is representing the AV nodal delay, right? And then QRS complex. So you should know about the normal intervals, right? Normal morphology and the normal interval, right? What is the normal PR interval? Normal PR interval is not more than 5 small square, means 200 milliseconds. It should not be more than uh, zero point 0.2 or 200 milliseconds, 0.2 seconds or 200 milliseconds. So if you see the the P wave is there, and then this is PR interval. So is it normal or abnormal? It's definitely abnormal. It's it's uh, it's prolonged, right? If you count the boxes, one, two, three, and then five, there's eight, and 8, 9, 10, 11. The 11 small squares. It is definitely prolonged. So there is constant AV nodal delay, abnormal AV nodal delay inside the AV node. So, and then this is followed by QRS complex. The PR interval is prolonged and it is fixed. It's not changing. If you count, it's 11 here, and then again 11 here, then 11 here, 11, so 11. The PR interval is prolonged and it is fixed. The second thing is that you should know how to count the heart rate over the ECG paper. It's very easy. If the if the rhythm is regular, if it is not irregular, you have this method of counting these large boxes, right? So QRS complex, if it is here, and the second, say for example, if it is falling over here, so the you will count like this, the 300. So the rate will be 300 if the second QRS complex is falling over there. And if it is falling over this second line, so the 300, 150. So the rate will be 150. And if it is not there, and if it is falling over this third line, right? So 300, 150, 100. Similarly, if it is falling over there, 300, 150, 100, 75. And then if it is there, then 60, 50. So what is the rate over there? 300, 150, 100, 75, 60. It is less than 60, right? It's something around 55 or something, 55. So this is in this way you can count the heart rate over the ECG paper. So what are our findings about this ECG strip? The PRS interval is prolonged, it is fixed, and the heart rate is less than 60. So these are our findings. And QRS complex is looking normal, and this is T wave, right? So if the PR interval is prolonged and fixed, this is the definition of first degree AV block, right? PR interval is prolonged and fixed. This is how you define the first degree AV block. So the rate is 60. It's regular. P waves are looking normal. PR interval is 0.36. Normal is 0.2, right? So it's 0.36. It's definitely prolonged. QRS duration 0.08. Interpretation first degree AV block. This is first degree AV block. The deviation from normal sinus rhythm, PR interval should, if it is more than 0.2, and etiology, prolonged conduction delay in the AV node or bundle of his. How will you treat this kind of patient? You should closely monitor the rhythm, and patient may need temporary pacing if the rhythm deteriorates. If the rhythm is not deteriorating, it's constantly first degree wave block. It's not going into not transforming into the second degree or third degree. Then there is no need of inserting the temporary pacemaker. You just need to monitor the patient and avoid AV blocking agents if the patient is taking rate limiting agents like beta blocker or calcium blocker. You should stop them and avoid using these kind of drugs. And generally, prognosis is good. Now, the rhythm 2, similarly, the PR interval, then QRS complex, T wave, then P wave. You can see the interval here, and interval here. And this is QRS complex, then T wave, then again P wave, PR interval. See this PR interval, and then this PR interval, and this PR interval. So what is it? It's progressively prolonged, right? Progressive prolongation of the PR interval, and then there is P wave and no QRS complex. So what is it? Progressive prolongation of the PR interval until P wave is not able to conduct into the ventricles, and there is a missed beat, missed QRS complex. So this is how you define the Wenke back, right? Rate 50 beats per minute. Regularity, it's regularly irregular, right? You can predict that after every 3 beats there will be a missed beat. Okay, P waves normal, but fourth no QRS complex. P interval lengthens progressively. QRS duration is 0.08. Interpretation is second degree AV block type 1. It's called Wenke back. Right? Deviation from normal sinus rhythm, PR interval progressively lengthens, then the impulse is completely blocked. P wave not followed by QRS complex. This is the typical presentation of the Wenke back, like second degree block type 1. Each successive atrial impulse encounters a longer and longer delay in the AV node until one impulse, usually the third or fourth, fails to make it through the AV node. Now there are rhythm 3, P wave, QRS complex, P wave, and then there is another P wave, no QRS complex. Then again, P wave, no QRS complex. P wave, QRS complex, P wave, no QRS complex, no QRS complex. P wave are there, but no QRS complex. So among the three, only one is going to conduct, and two beats are failed to conduct into the ventricle, right? So what is this? And how you can count the rate over the ECG paper? Same, 300, 150, 100, 75, 60, 50, 40 is less than 40. It's a serious kind of bradycardia, right? Less than 40 beats per minute, regular. P waves looking normal, morphology is normal, but 2 of 3 don't have QRS complex. P interval 0.14. The P interval is normal, right? P interval is normal. But 2 P waves, they are not followed by QRS complex. So there is no, you cannot come in over the P interval uh, with these P waves. QRS duration, it's looking normal, 0.08. Interpretation, second degree block type 2. So this is the serious kind of AB blocks, the high 80 degree AB block. Deviation from an normal sinus system, occasional P wave are completely blocked, P wave not followed by QRS. Conduction is all or nothing. No prolongation of P interval. Typically, block occurs in the bundle of his. Temporary pacing is needed because you see that the heart rate is less than 40, and usually if the heart is less than 40, so there's a hemodynamically instability, and you need to give some kind of support to your patient. So look for reversible causes. If the rhythm does not reverse, permanent pacemaker should be implanted. Initially temporary pacemaker to support the heart, and then if the rhythm is not going to normal and the cause is irreversible, then a patient may need permanent pacemaker and it should be implanted. Generally, prognosis is bad and patient is dependent on permanent pacemaker. Now, what is this? Now you can see the abnormal QRS complex. In last 3-4 rhythm, you have seen the narrow QRS complex, right? And now you can see the broad QRS complex. Now it's obviously abnormal kind of QRS complex. Normally the QRS complex not more than 0.1 second or 100 millisecond. Like you can say that it's 2.5 small square, right? This is the small square, and this is the another. So if it is more than 3 small square, it's obviously abnormal. The QRS complex. QRS complex should not be more than 3 small square. And here you can see 1, 2, 3, 4, and 5, 6, 7, 8, 9, 10. It's huge. It's obviously abnormal. So QRS complex is broad, and then P wave here, P interval, P wave here, and prolonged P interval. Then the P wave is here. It's buried in this QRS complex. See, this is P wave. And then this P wave, then again P wave, P interval. So the P interval is not fixed. It's short here, it's very prolonged here, it's prolonged here. So P interval is constantly changing. It's changing. It's variable. And PR interval is changing. It's variable, it's not fixed. And QRS complex is broad. And what is the rate? 300, 150, 100, 75, 60, 50, 40. So it's less than 40. So less than 40 heart rate, QRS is obviously abnormal, it's broad, and PR interval is not fixed, it's variable. And what is the rate of the P wave? You can count the rate of the P wave as well over the ECG paper. So you see, this is the P wave, and this is the second P wave, right? So 300, 150, 100. So the rate of the P wave is around 80. Okay, 300, 150, 100. So it's, the P wave, the rate is different from the rate of the QRS complex. QRS complex, the rate is less than 40, and the P wave rate is 80, and a variable PR interval. So it's called the AV dissociation. There is no association between the P wave and the QRS complex. Normally, each P wave has to conduct into the ventricle, and the rate of the P wave and the QRS complex should be normal, should be equal, right? Should be equal normally. And if there is a difference between the rate of the P wave and the QRS complex, it means there's no association between the P wave and the QRS complex. The ventricle has its own rate, and the atria have their own rate. So there is complete dissociation. It is called AV dissociation, and it is called third degree AV block. Rate 40 beats per minute, regular P waves. See, these are the P waves we already discussed. No relation to QRS complex. PR interval, none. QRS duration, void, more than 0.12. And temperature, third degree AV block. This is called third degree AV block. Complete dissociation between the atria and the ventricles. Deviation from normal sinus, the P waves are completely blocked in the AV junction. QRS complexes originate independently from below this junction. And if the ventricle has its own rate, it's called escape rhythm, because every P wave is buried, it's blocked inside the AV node, and there's no way to go inside the ventricle. So the ventricle has to generate its own rate, and it's called escape rhythm. There's complete block of contraction in the AV junction, so the atria and ventricles form impulses independently of each other without impulses from the atria. The ventricle's own intrinsic pacemaker kicks in at around 30 to 45 beats per minute. And the treatment is immediate implantation of the temporary pacemaker, and then if the cause is irreversible, then you have to put the patient on permanent pacemaker. This is temporary pacemaker, right? And this is the TPM lead, temporary pacemaker lead. So, so this is the proximal part of segment of the TPM lead, and it should be inserted into the temporary pacemaker device. This is the distal part, and you have to insert this distal part into the right ventricle, right? From the venous approach. From the femoral vein, from the subclavian or internal jugular, whatever is easy for the patient or for the operator, you have to get the access through the vein, and then you should go inside the right ventricle and then place this temporary pacemaker lead inside the right ventricle, and then you can generate the impulse through the temporary pacemaker. This is a permanent pacemaker device. Permanent pacemaker device, subcutaneous implantation, and then this lead again through the subclavian vein inside the right ventricle. Okay, so this is all about the bradyarrhythmias. Now, if we have time, then we can discuss tachyarrhythmias. Okay, can you see the new slideshow? Can you see the
Yes, sir.
new slideshow? Okay. So we have supraventricular arrhythmias and ventricular arrhythmias. Sinus arrhythmias, premature beats, supraventricular arrhythmias, ventricular arrhythmias, AV junction blocks. And commonly we have atrial fibrillation and atrial flutter. So now this is rhythm 1, and you can see the QRS complex and in QRS complex, QRS complex, QRS complex, but there is no definite P wave, right? You can see the fibrillatory wave, but there is no definite P wave. And QRS complex, you see the duration between the QRS complex constantly changing. It's variable. So there are two typical findings, and if you have these two typical findings over the ECG, then it's very easy for you to diagnose the rhythm. So if the P wave is absent, or you see there is no definite P wave, and only you can see the fibrillatory waves. And the second thing is that if there is varying RR interval, this is varying RR interval, varying RR interval, R to R variable, variable RR interval. So these are the two findings. And if you have these two findings, then the diagnosis is very easy. It's called atrial fibrillation. How can you calculate the heart rate over the ECG paper if the rhythm is irregular? The method that I have told you earlier, it's not applicable over here, right? 300, 150, 100, 100 is there, and 300, 150, it's more than 100 here over here, right? Here, 300, 150, 100, 75, 75 is there. So the method of calculating heart rate that I have told you earlier, it's not applicable over here. So how can you calculate the heart rate if the rhythm is irregular? Like in atrial fibrillation, rhythm is always irregular in case of atrial fibrillation. So you need to have a 6-second strip, right? And how can you get the 6-second strip? If you have 30 large boxes over the ECG paper, it is equal to 6-second strip. Like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. So this is exactly the 6-second strip. If you have this 6-second strip, now what you have to do next? You need to count these QRS complexes over this 6-second strip. How many QRS complexes over this ECG strip, over this 6-second ECG strip? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So you have 10 QRS complexes over this ECG strip, over this ECG 6-second ECG strip. Now you need to multiply this count, this number by 10. So 10 means 100. So this is the 100 rate. Okay. You need to have 6-second strip. Now, the second thing is that you need to count the QRS complex over this 6-second ECG strip, and whatever the number you have, you need to multiply it by 10. So this is the another way to count the heart rate over the ECG strip if the rhythm is irregular. So this is 100. Okay. Rhythm is irregular, P waves absent, P interval is none, QS duration looking normal, interpretation, atrial fibrillation. This is very common type of arrhythmia, and day in and day out we have to encounter with this arrhythmia, atrial fibrillation. It's called atrial fibrillation. You must know about this, and you should be able to diagnose this atrial fibrillation over the ECG. But just remember these two findings: varying RR interval and absent P wave. No organized atrial depolation, so no normal P waves and pulses are not originating from the sinus node. Atrial activity is chaotic, resulting in an irregular rate. It's common, affects 2 to 4%, up to 5 to 10% if in elderly patients. Recent theories suggest that it is due to multiple reentrant wavelets conducted between the R and L, right and left atria. Either way, impulses are formed in a totally unpredictable fashion. The AV node allows some of the impulses to pass through atrial intervals. So rhythm is irregular. Affects 2 to 4% of population, increases to 5 to 10% of patients over age of 80 years. Associated with twofold increased risks of death. Risk of thromboembolism is approximately 5% per year, but maybe as high as 20% in high risk groups if they are not anticoagulated. So this is the very common complication of the atrial fibrillation, because there is no proper conduction of the current, and there are many impulses inside the atria. So there is no proper contraction of the atria, and atria is just like a bag of worms. It's fibrillating. It's a fibrillating kind of chamber. So what happened next? There is stasis of the blood inside the atria, and this stasis, if it is prolonged, then it causes uh, thrombus generation, clot formation inside the atria, and it leads to thromboembolism and stroke and liver function and renal function. Wherever it goes, this thrombus of this clot, wherever it goes, it causes infarction. Maybe cerebral function like stroke, liver function, renal function, splenic infarction, mesenteric infarction. But commonly, we have in clinical practice we have stroke, thromboembolic stroke, and the cause is most of the time it causes atrial fibrillation. Common causes of atrial fibrillation: hypertension, ischemic heart disease, fibrotic heart disease like MR, MS, and chronic lung disease, pulmonary embolism, hyperthyroidism. And if there is no cause, then lone AF is usually in elderly population. So there are multiple causes of atrial fibrillation, and I think we can skip this management, cover the other common arrhythmias. So this is the rhythm 2. Again, QRS complex, but you can see the morphology of the P wave. The morphology of the P wave is different over here. It's not normal, right? And if you remember, if you see the sawtooth appearance, right? This is typical of atrial fibrillation. If you see this sawtooth appearance of the P wave, then the diagnosis is atrial flutter. And what is the rate? The rate is 300, 150, 100, 75. So it's around 80. QRS morphology is normal. Heart rate is around 80, and sawtooth appearance of the P wave. The rate is 70 beats per minute. Regularity, regular. P wave, flutter waves. Peer interval, none. Pulse duration, 0.06. It's normal. Interpretation is atrial flutter. Right? No P wave, instead flutter waves, no sawtooth pattern are formed at a rate of 250 to 350 beats per minute. Only some impulses conduct through the input, usually every other impulse. Reentrant pathway in the right atrium with every second, third, or fourth impulse generating a QRS. Others are blocked in the AV node as the node depolarizes. So, atrial is very atrial flutter all over the ECG. You need to have the sawtooth appearance, and that's all. If sawtooth appearance over there, then it's very easy. And if the sawtooth appearance is not there, and you're suspecting atrial flutter, so what you need to do? You need to do count the rate of the P wave. If you have two P waves, right, like there, here. If you have two P waves, just count the rate of the P wave. The P wave is there, and if the second is falling over there, then the rate of the P wave is 300, right? Like here. Here the rate of the P wave is it's equal to 300. Okay, if the P wave rate is 300, it must be flutter. If the P wave rate is 150 to 250, it's paroxysmal atrial tachycardia, and 250 to 350, it's atrial flutter. And if it is more than 350, then it's atrial fibrillation. So this is how you can differentiate between the atrial arrhythmias, right? Now the rhythm 300, 150, 100, 75. Right? So less than 75, 70. The QRS, the rate, QRS rate. Peer interval is normal. Again, peer interval is normal. Peer interval normal. Okay, normal. But suddenly, the rate of the QRS complex, it's changing. Or this is normal rhythm. This is abnormal rhythm. There's no tachycardia over here. Tachycardia over here. And the rate is around 70 over here, 300, 150, 175, right? And here it's about 150, 300, 150. Those sudden changes of the rhythm, and normal here, tachycardia here. Or no P wave, no obvious P wave. You can see P and P interval over here, but there's no P wave, definite P wave over here. So what is this? 75 to 148 heart rate, and regular to regular, yes. P waves normal to none. P interval 0.16 to none. 0.16 over here, but no P interval over here. QS duration 0.08. Interpretation supraventricular tachycardia. This is called supraventricular tachycardia, proximal supraventricular tachycardia. Okay. Now, these two are the life-threatening arrhythmias: ventricular tachycardia and ventricular fibrillation. The QRS complexes are broad, okay, and tachycardia over here. What is the rate? 300, 150. It's more than 150, right? 300, 150. So there is definite tachycardia, and the QRS complex are morphologically it's broad. So the origin of QRS complex is from the ventricle. So this is called ventricular tachycardia, right? Rate 160, regularity regular, deviation none, peer interval none, QRS duration wide. It's definitely wide. It's more than 3 small boxes, right? You can see over here more than 3 small boxes. So it's definitely wide. It's definitely wide. It's definite tachycardia. So it's called ventricular tachycardia. The cause is originating in the ventricles. No previous white QRS. There's a reentrant pathway looping in a ventricle. Most common cause. Ventricular tachycardia can sometimes generate enough cardiac output to produce a pulse. At other times, no pulse can be felt. So if the ventricular tachycardia is not hemodynamically unstable, if patient is stable, if it's not creating any abnormality, like if you have the patient is conscious, pulse is there, and BP is normal, it's called hemodynamically stable tachyarrhythmia. And in case of hemodynamically stable tachyarrhythmia, you don't need to give that patient electrical current. You can manage this kind of patient with medications, with pharmacological, like it's called pharmacological cardioversion. So in case of hemodynamically stable tachyarrhythmias, any tachyarrhythmia um, uh, that is not causing hemodynamically instability, you can manage this kind of tachyarrhythmia with drugs, with medicines, IV medications like imidrone, like lignocaine. So you can try medications if the patient is stable. But if the patient is unstable in any tachyarrhythmia, if there is hemodynamically instability, if the patient is not stable, if you don't feel any pulse, if there is no BP, if the patient is unconscious, then you have to have to show the urgency, the emergency, and you need to give the electrical current to the patient. This is called electrical cardioversion, DC cardioversion. So these kind of patients need DC cardioversion. Common causes ischemic heart disease, cardiomyopathy, arrhythmogenic right ventricular dysplasia, long QT syndrome, Jacobson toxicity, idiopathic VD. Okay, so rhythm 5, there is no QRS complex, no normal QRS complex, no P-wave, just chaotic activity. What, what is this? This is ventricular fibrillation, life-threatening tachyarrhythmia. Don't delay the treatment. Don't delay the treatment. And the treatment is defibrillation, electrical defibrillation, electrical defibrillation. There is no other way. Deviation from NSR completely abnormal. The ventricle cells are excitable and depolarizing randomly. Rapid drop in cardiac output and death occurs if not quickly reversed. So you have to show the urgency, the emergency. There is no other treatment. If you have ventricle fibrillation, the treatment is electrical defibrillation. Defibrillation, defibrillation, defibrillation. Now quickly identify the rhythm. Rate is 150, 300, 150. And you see the sawtooth appearance, right, of the P wave, sawtooth appearance. This is atrial flutter. Varying RR interval, no definite P wave. See, no definite P wave, varying RR interval, atrial fibrillation. Again, varying RR interval, no definite P wave. No definite P wave. Only some fibrillative waves are here. Okay. Again, atrial fibrillation. Broad QRS complex, right? And tachycardia, ventricular tachycardia. And it is called polymorphic because the QRS complex, the morphology of the QRS complexes are constantly changing, right? It's different over here, different over here, different over here. Okay. Different kinds of, so it's called polymorphic VT. So again, it's a very life-threatening kind of ventricular tachycardia, and it can easily transform into the ventricular fibrillation if the treatment is delayed, right? Again, broad QRS complexes and tachycardia. This is ventricular tachycardia, and you can see that it rapidly changes into the ventricular fibrillation. The treatment is delayed, ventricular fibrillation is there. Okay, it's life-threatening kind of ventricular tachycardia. Again, the polymorphic VT is called Torsades D point. This polymorphic type of VT, and it can easily transform into the ventricular fibrillation. Again, polymorphic VT, or that polymorphic VT transform into the ventricular fibrillation. Okay, thank you so much. So this is all about arrhythmias. We have covered bradyarrhythmias and then tachyarrhythmias, common kind of bradyarrhythmias and common type of tachyarrhythmias. Thank you so much.